Good morning, everyone. I'm Dr. Jonathan Tan from Singapore, and today I'm presenting our study and the evaluation of prognostic scoring systems for survival in a surgically treated cohort of 318 patients. I have no conflicts of interest to declare. Now, survival for prognostication plays a key role in the decision-making process for patients with spine mets. Traditionally, we would not offer surgery to a patient who is expected to survive less than 3 months, while more aggressive surgical treatments such as an en bloc spondylectomy were reserved for patients with a longer predicted life expectancy, for example, more than 1 year. And this has led to a proliferation of scoring systems as the modified Tokuhashi score, the Tomita score, the modified Bauer score. I'm sure most of us in this audience are familiar with these scoring systems. But these older prognostic scoring systems are experiencing a progressive loss of accuracy. The modified Tokuhashi score is probably the most popular score that's in use. And you can see that in this study of 1,686 patients published in 2016, the total predictive accuracy was only 63%. So that's led to the introduction of new machine-based learning algorithms such as the SORG score or GSTSG score to overcome this. Now, the aim of my study is to compare the accuracy of both legacy and current prognostic scoring systems in patients with surgically treated spinal metastases. This is a retrospective review of 318 surgically treated patients between 2009 to 2021 at my institution in Singapore. And we will compare the predicted survival based on prognostic scoring systems at 3 months, 6 months, and 1 year, and compare it against actual survival. We studied the sensitivity, specificity, PPV, and PV of the scoring systems, and the most important was the area under the ROC curve for these scoring systems. These were the scoring systems which we analyzed. So in terms of, for my study, in terms of demographic data, the mean age was 61 years. The median survival was about 16 months post-surgery, more females than males, and these were the most common sites of primary malignancy, the lung, followed by the breast and the prostate. For predicting 3 months survival, most of the scores could get area under the curve of more than 0.8, including the modified Oswestry score, the New England Spinal Metastases score, GSTSG and SORG machine-based learning algorithms. But when it comes to predicting 6 months survival, only the modified Oswestry score managed to have a clinically significant area under the curve. And then, for predicting 12 months survival, only the New England Spinal Metastases score was able to predict 1 year survival with a ROC of more than 0.8. So, as for discussion, there's no one scoring system at this point in time which can accurately predict survival at all 3 of these time points. And we found that the majority of our patients actually outlived their prognosis. There's a need for a multidisciplinary approach in approaching these patients. You cannot rely on the scoring system alone. Even if you look at this paper here, when you ask an oncologist to predict 6 months survival, their area under the curve is actually 0.78, which is a bit less than 0.8. So it needs all of us to be able to actually decide what is best for the patient. And another thing to take note of is that it's not quality of life for the patient, not quantity of life, but actually quality of life that matters. And even patients with a poor survival prognosis can still benefit from surgery. This is a paper from Leow et al. They found that even patients with a less than 3 months life expectancy still can experience an improvement in quality of life at 6 weeks after surgery. So we should not discount these patients even though they have a poor prognosis. In my practice, I do not use one prognostic scoring system alone to predict survival because they are unreliable at different time points. I rely on a multidisciplinary approach. I speak to the oncologist, I speak to the palliative physician and discuss with them to get a better idea of how long the patients are going to survive for. Oncological factors that I find very important and which we'll see consistently in all papers there is the tumor type. And in particular, we should always see if the tumor type is sensitive to the newer targeted therapies. Extent and progression of disease, which is also in all the studies. But I think that that's not in the studies is how fast the disease is progressing. If you compare a CT thoracic cerebral pelvis from 6 months ago to 1 year later, how much the tumor has progressed in the time, that will give you an idea of how the patient is going to do, and whether the patient has other further chemotherapy options. And finally, patient factors, functional status is extremely important, whether you use the ECOG score or the Karnofsky performance score, as well as comorbidities. Thank you very much.
Thank you very much.